results of a phase 3 study called Genuine were presented by Dr. Sherman. This study is a phase 3 study of ibrutinib versus ibrutinib plus ublituximab in patients with relapsed refractory high-risk CLL. Ublituximab is a glycol-engineered anti-CD20 monoclonal antibody which has enhanced ADCC. In this study, centrally confirmed high-risk patients having deletion 17p with or without TP53 mutation or deletion 11q were randomized to either receive ibrutinib at standard dose or ibrutinib at standard dose plus ublituximab given at 900 milligrams on day 1, 8, and 15 of cycle 1, and then day 1 of cycle 2 to cycle 6. And subsequently, this is different from other studies that have similar studies that have been conducted. There was a maintenance of ublituximab given every 3 months thereafter. 117 patients were accrued on this study, 59 in the ublituximab plus ibrutinib arm, 58 in the ibrutinib alone arm. Baseline features were pretty similar between the two arms, except there was a slightly greater number of deletion 17p in the ibrutinib monotherapy arm, and bulky disease was seen more commonly in the combination arm. IGHV unmutated status was seen in 83% of patients in both arms. Adverse events were as expected, except infusion, and they were similar between the two arms, and except infusion reactions, which of course were seen more commonly in the ublituximab plus ibrutinib arm, seen in about 53% of the patients, although grade 3 and 4 was only seen in 3% of the patients. Neutropenia was also more common in the combination arm, seen in about 36% of the patients versus 21% of the patients in the ibrutinib monotherapy arm. At a median follow-up of 42 months, all efficacy endpoints were in favor of the monoclonal antibody containing arm, that's ublituximab plus ibrutinib. So this is actually the first phase 3 study which has shown a randomized study, which has shown a progression-free survival benefit when compared to monotherapy with ibrutinib. And also interesting with this study was the maintenance treatment, which was given in the monoclonal antibody containing arm. As you went beyond the first year, both the CR rates and the MRD negative rates continued to improve, suggesting there may be a role of maintenance therapy in these patients. So yes, these were some of the interesting abstracts. There's always something interesting going on in the CLL world.